Hello, everyone. It gives me great pleasure to start this inaugural session of this new initiative by IASNM, the IASNM Radiant Flashpoint Educational Web Series, in honor of the late Dr. Sam Gambhir, who was one of our past presidents, and in collaboration with MISI, the Molecular Imaging Society of India, for whom Dr. Sam Gambhir contributed a lot as well. It gives me great pleasure to dedicate these educational web series in his honor. And I'm going to start this web series with the first talk or first session. The topic today is molecular imaging and theranostics, the current state of the art and future perspectives. And thanks, Saima, for that kind introduction. So without further ado, let's start. And first things first, I don't have any relevant disclosures pertaining to this talk. I am a consultant for Curium Radiopharmaceuticals and adaptive research that's trying to bringing change to research. The learning objectives for this talk is we're basically going to review the development of nuclear medicine and its evolution to molecular imaging. Evaluate the current state of molecular imaging in the US per se, with specific probes in current use as well as on the horizon, and discuss the current and future potential applications of theranostics. Again, the focus is going to mostly be in the US since I'm based in the US. So nuclear medicine, as we all know, is a small field, but relatively diverse. We have the diagnostic nuclear medicine component, which pertains to general nuclear medicine scans, all the different kinds of scans that we use using various radioisotopes, like the bone scans, the VQ scans, GI bleeding scans, thyroid scans, brain spec studies, octreo scans, lymphoscintigraphy, and a whole bunch of other scans. Then we have nuclear cardiology, which is kind of considered a separate diagnostic branch of nuclear medicine, where we do perfusion, SPECT imaging, MAGA studies, and viability studies. There are some non-perfusion based studies like for adrenergic innervation and amyloidosis that can be considered part of nuclear cardiology as well. And then we have PET, which is, again, a diagnostic nuclear medicine entity, but it's considered separate from general nuclear medicine because the tracers we use for PET are slightly different than general nuclear medicine radioisotopes, and the scanners we use are slightly different as well. And PET has applications in oncology, neurology, and cardiology. Then we have the therapeutic aspect of nuclear medicine, and we've been doing therapies for a long time, actually. So the first applications of nuclear medicine were actually therapeutic, not diagnostic. And isotopes like P32 were used in the 1930s to treat cancer, as well as iodine was used in the early 1940s for thyroid cancer as well. So we've been doing I-131 treatments for hyperthyroidism and thyroid cancer for a long time. Strontium and samarium were used for bone metastasis palliation, especially in prostate and breast cancer. That is waning out. The older agents like P32 are hardly in vogue. Briefly, in early part of 2000, we had Bexer and Zevalin for non-Hodgkin's lymphoma. We treated a fair number of patients, but that is not in vogue much now. Then Xofigo, or radium-223 dichloride, was the first alpha emitter that is used for castrate-resistant prostate cancer with bone predominant disease, and that is still in use. New kid on the block is Lutathera, or lutetium-177 dotatate, for neuroendocrine tumors, and we're expecting approval of PSMA-based therapies for prostate cancer in the very near future in the US, and that should pave way for more therapeutic applications for nuclear medicine. And then a significant amount of nuclear medicine remains in the research arena, where a lot of tracers and other theranostic agents are being studied in the preclinical as well as clinical setting. So as you can see, nuclear medicine is kind of diverse and goes from not just diagnostic applications, but to therapeutic applications as well, along with research entities. So we know we started with rectilinear scanners, then Hal Engr made or invented the gamma cameras or Hall Engr cameras, and that led to the advent of planar nuclear medicine images or planar projections of nuclear medicine images that evolved into SPECT. And SPECT actually, SPECT stands for single positron emission computerized tomography. And the principles of SPECT were laid down in the 1950s and 1960s. And that actually led to the development of a CT scan as we know today, because those same principles were applied to X-ray imaging, and that's how CT came into existence. So SPECT actually precedes CT. And then now we have SPECT CT, which has made a significant impact on our general nuclear medicine scans, especially for parathyroid scans, bone scans, infection imaging, even some GI bleeding scans. So we now are in the era of hybrid imaging, where we're combining anatomic and functional or physiologic modalities like SPECT CT, PET CT, PET MR, and that has led to a drastic, a significant change in how imaging is pursued, because now you're getting the best of both worlds. We're getting good anatomy as well as great functional or metabolism imaging. And that has been a game changer and has been at the forefront of development of molecular imaging. So here's an example of a radionuclide bone scan, and you can see that there are a few lesions that one of them may be concerning the other, may be potentially degenerative, but you cannot exactly exclude a more serious underlying pathology. So in the era of SPECT, we got better resolution, better localization of the lesion, but still something was lacking till SPECT CT came into play, and we can exactly see where that lesion is on CT, what type of lesion it is. Is it sclerotic? Is it mixed? Is it lytic? Is it a fracture? Is it degenerative change? And we can give much more robust evaluations with the SPECT CT. Same is true for parathyroid imaging, where you can localize the abnormality more precisely, whether it's in the tracheoesophageal groove, or it's within the thyroid, or it's an ectopic parathyroid, as is shown in this case. That there's an ectopic parathyroid adenoma that was detected with this SPECT CT. SPECT CT is also important for WBC imaging, where we have a lesion in the right foot of this patient, and you can, with SPECT CT, you can clearly see where it is precisely localized. So we went from this kind of an image to this kind of an image, which gives you much more details and really has an impact on management of patients. Even in dynamic studies like GI bleeds, SPECT CT can be useful to localize the source of bleed. So here you can see a positive GI bleeding scan in the right abdomen, probably starting somewhere in the right colon near the hepatic flexure region, but the SPECT CT actually localizes it much more precisely to the anastomotic site in this history of prior colon surgery. And so again, even in dynamic studies where one would think that SPECT CT would not be that useful, it still can be useful in select situations. And this is just to show how SPECT CT has come along, and now more and more applications are being done with SPECT CT rather than with planar images. This is a GE Discovery PET CT scanner with a lot of bells and whistles. It's got an IV contrast injector. It's got a C-arm for step and shoot CT, and potentially you could do either CT or PET CT guided biopsies. Not being shown here is a variant semiconductor-based camera system that can be used for respiratory gating, and it's a time of flight machine. So that basically shows that it's a pretty high-end machine. And this SNMI image of the year in 1999 was when kind of the first PET CT scanner, the prototype was actually in 1998, but this image was in 1999, showing the value of joining functional imaging and anatomic imaging in the form of a PET CT scanner. And that has revolutionized the way we do PET imaging nowadays as well. So what is PET? PET is basically a nuclear medicine imaging technique that provides tomographic images of a substance of interest, which is tagged to positron emitting radiopharmaceuticals. The technique was actually introduced in the late 1970s, so it's been there for a long time. And initially, it was focused more on brain imaging than on cardiac imaging. It was in the late 1990s that we started getting to know better the value of FDG PET in oncology, and it became mainstream in the first decade of this century when its applications in oncology started to explode. FDG still remains the most common PET radioisotope used for imaging, and it provides a map of glucose metabolism of the body. And some consider it the molecule of the 20th century. It's had such a big impact in the management of cancer. So the clinical applications of PET consists of oncology, where FDG is still the most common entity used for initial and subsequent treatment strategy of many cancers. But again, there are notable exceptions. F18 sodium fluoride bone PET CT is still done at some places, but is not very common. Gallium-68 and now more recently copper-64 dotatate is used for neuroendocrine tumors. Then we have F18 fluciclovin or oxamin and gallium-68, as well as F18-based PSMA radiopharmaceuticals for prostate cancer. And lastly, we have F18-based fluoroestradiol for breast cancer, or FES. Trade name is Cerianna. In neurology, we have FDG PET for dementia evaluation, along with amyloid plaque agents, F18 fluor-beta pair, fluor-beta-ben, and flutamidamol, as well as a tau agent that has been FDA approved called fluortaucipir or Tauvid. FDG can also be used for seizure-focused localization, evaluation of brain tumors, especially after radiation therapy to assess between post-therapy change and recurrence. And in HIV patients with ring-enhancing lesions on MRI, FDG PET is used to differentiate between CNS toxoplasmosis and CNS lymphoma. And lastly, we have cardiac PET applications. Just like SPECT myocardial perfusion, we can have PET myocardial perfusion with either rubidium 82 chloride or N13 ammonia. We can do scans for myocardial viability, evaluation of scar, evaluation of sarcoidosis or infection in the heart. You can combine the FDG metabolism with either a PET rest perfusion or a SPECT rest perfusion. You can also combine the perfusion studies that can be done with stress and rest with either a coronary artery CT angiogram or a calcium scoring study, and give much more robust evaluation of the cardiac status of the heart. And recently, CMS took away the non-coverage determination for infection inflammation imaging. So that's going to open up another avenue for utilization of FDG PET imaging, at least in the US. So we've come a long way from radioiodine for thyroid diseases in the early 1940s to molecular imaging with the prototype PET CT in 1998. I've been talking about molecular imaging. So what's the difference between molecular imaging and conventional imaging? So conventional imaging is more anatomy or structure based, and we are trying to find out the end effects of what's happening after molecular alterations have taken place at the tissue and cellular level. So you're basically detecting mass or soft tissue stranding and those kinds of things, whereas molecular imaging is trying to detect the disease process at an earlier level by interrogating the biological processes happening in a living person at a cellular or tissue level, and pick up the abnormalities that form the pathophysiological basis of disease. And so this term molecular imaging is a new imaging paradigm, and it encompasses multiple things like image capture techniques. It has cell and molecular biology applications, chemistry or biochemistry involvement, of course, pharmacology, medical physics, even biomathematics and bioinformatics. So it's not the typical imaging that we've known in the traditional sense, but it has an array of things that influence it, and it's very involved. So it entails visualization, characterization, and measurement of biological processes. So all these terms are important. It's imaging, so you have to visualize things, but at the same time, you have to characterize the processes happening at the tissue level better. And we need something that is measurable so we can consistently measure it, and also measure the changes happening with intervention, for example, with some therapy. And so those are important considerations when we develop new molecular imaging probes. And techniques include radiotracer imaging, especially the new PET probes or molecular imaging probes, but MR imaging with MR spectroscopy, optical imaging, especially with some fluorescence and bioluminescence imaging, ultrasound with contrast microbubbles, which can be targeted by coating them, coating the surfaces with different things, can also play a role in molecular imaging. But as of now, the predominant thing that is driving molecular imaging is PET imaging with different molecular or PET probes. So what's the relevance of molecular imaging? So it's basically giving you more about the disease biology at a cellular or tissue level, and it helps you characterize the disease process better at an individual level, and thus helps in giving personalized care. And thus it is basically going to help play a critical role in implementation of P4 medicine in the 24th century. And P4 medicine stands for predictive, preventive, personalized, and participatory medicine. So the scope of molecular imaging right now is mostly for chronic conditions like cancer that has now become almost like a chronic disease, cardiovascular diseases, various neurological diseases. And its impact on clinical and preclinical research is set to expand as well. It has got a significant role in making translational research from bench to bedside much more efficient. It can perform a very efficient and effectively large amount of pharmacokinetic and pharmacodynamic studies, and that will help to translate discoveries much more faster from the lab to the clinic. And ultimately, it will provide for early detection of diseases and enable rapid therapeutic decisions, as well as changes in decisions, basically. A lot of biotech companies and pharma industries have bought micropet or microspec and PET and CT trimodality scanners for animal experiments to help rapid development of new drugs, basically. Here is an example of a restaging PET scan, just to show you the impact of PET imaging or molecular imaging. This is a 36-year-old patient with history of breast cancer and colorectal cancer, and PET CT was performed for restaging or subsequent treatment strategy after adjuvant chemotherapy. And you can see that there's a lot of disease in the supraclavicular region, as well as this lung nodule in the left lung, which is obvious, but there is a very subtle focus in the liver that is barely seen on the MIP image, but was better seen on the fused transaxials. There was nothing on the CT. They also did a liver triple phase CT scan and an MRI, and basically nothing was found. So they thought that this is just noise or artifactual, something non-specific, because we are looking at glucose metabolism and not necessarily as cancer. But look what happens just 5 months later. That small left hepatic lobe lesion progressed so rapidly that it's involving almost the entire left hepatic lobe, and has multiple other lesions within just a 5-month period. Here's another example of a tiny lung nodule in a 56-year-old male with hypopharyngeal cancer that was treated with chemoradiation, and PET was done for subsequent treatment strategy. Pretty good response in the head and neck region, just post-therapy changes, but there is this tiny 5-millimeter nodule that's technically below the spatial resolution of PET, but it showed a hint of activity. The activity was better seen actually on the non-attenuation corrected images. I was worried that we should not be seeing any activity. Why is this lighting up a little bit? And then 6 months later, we can see that rapid progression of that lesion. So this is just to show that these probes indeed help you pick up disease much more earlier. And yes, granted that sometimes they are non-specific, but lots of times it's actually a true positive lesion. We are basically hampered by the fact that we still need tissue because this is not a cancer-specific agent. And for tissue, we have to do CT or ultrasound-guided biopsies. And if the lesion is not seen on ultrasound or CT, then usually a biopsy does not happen. And lots of times, as we can see, this is still anecdotal, but this happens not infrequently, that PET is right, and we have large amount of disease that flares up when we're picking up disease in very early phase kind of a thing. This is very well known to most of us who do PET imaging, is the impact of PET in lymphoma. In fact, we have changed the response assessment criteria for lymphoma based on PET. So here is a young male patient with Hodgkin's disease. This is the initial treatment strategy, CT and PET, pretty matching with a lot of mediastinal disease. Prominent on the CT, enhancing lymphadenopathy, as well as intensely FDG with matching lymphadenopathy on the PET scan. And this is the CT scan post-treatment, and you can see that there's a significant regression, but there's still residual abnormalities. So this CT would have been read as a good response, but presence of residual disease. So this would be a partial response potentially, but the PET is completely clean. And so what all is remaining is mostly just inactive disease or fibrous tissue, because as the lymph nodes shrink, they become fibrous, and some of them may never go away completely. And so there may always be a small amount of residual soft tissue abnormality that will remain stable for some time. And after 3-4 scans, that's when we start calling them, hey, it's stable, so it's probably not active disease kind of a thing. But till that time, patient keeps on getting chemotherapy, which may not be giving any more benefit, and it is certainly causing some toxicity, as well as it is causing a burden on the healthcare expenses. Whereas the PET is actually showing that the patient is clean, and just a couple more cycles of chemotherapy should be more than enough to give a prolonged and durable response. PET has a significant role in lymphoma. This is a initial treatment strategy scan for a patient with lymphoma. You can see that this is extensive stage disease, stage 4, with lymphadenopathy on both sides of the diaphragm, as well as visceral involvement, specifically bone marrow involvement. And after 2 cycles of ABVD chemotherapy, you can actually see that the disease has progressed. So instead of waiting for 6 cycles and then assessing, we can look at the disease after 2 cycles and pretty accurately predict whether the response is working or not. In this patient, the treatment was changed to the MOPP regimen, and after 2 cycles, you can see there's a complete response. And so 2 more cycles of MOPP regimen in this patient should suffice, followed by maintenance therapy. So we have this concept of IPET, and I here stands for actually interim PET. And so you basically want a almost clean or clean scan after 2 cycles to predict a durable and sustained response. If you see something like this, where there is response, but there's still considerable amount of disease remaining after 2 to 3 cycles, then usually these patients don't do well. In spite of having a response, you want a fantastic response, because lymphoma just melts with chemotherapy. So these, even after 4 cycles, there's going to be some, the PET may turn negative, but there is residual amount of disease left, and that's going to come back with a vengeance. And the rationale for this is, suppose you have 3 cell lines, one of them responds pretty fast, and this patient becomes negative after 2 cycles. After 2 more cycles, he'll go to cure. This patient B responds slightly slower, so there's some amount of disease left, but it is barely visible. And after 4 more cycles, this patient will go to cure. Whereas this patient C, who has response, but there's considerable amount of disease remaining, After 4 more cycles, the patient may not have any detectable disease, but probably has significant amount of viable tumor cells left. And when you stop chemotherapy here because there's undetectable disease, it comes back with a vengeance. And so that's why patients C, which is something like this, don't do well long term, whereas patient A, which is something like this, do very well with 2 more cycles, or patient B with 4 more cycles. So this is something that's very interesting and is going to help us detect responders from non-responders and make appropriate changes in therapy sooner rather than later. And so moving on, switching gears a little bit, we have another agent other than FDG, which is dotatate PET, which is used for neuroendocrine tumors. So this is basically an HD octreoscan. In this patient, this is a 65-year-old with malignant carcinoma of the duodenum, status post resection, had metastasis to the liver and pancreas, had TACE therapy, and then is currently on lanreotide. CT showed progression in the liver lesions, and an octreoscan did not show any significant disease burden, whereas gallium-68 dotatate showed multiple unsuspected lesions. So all these lesions in the chest and supraclavicular region were kind of unsuspected. There were other lesions scattered elsewhere in the abdomen. So we pick up so many new lesions with dotatate PET scans that we actually tell the referring physicians that don't consider this as disease progression. Let's call this as a new baseline, because a lot of these lesions would have been missed on octreoscans, scans, and there was no other good agent previously to look at these. So we call this as a new baseline, and you start from here and then follow up. So gallium-68 dotatate, trade name NetSpot, was FDA approved in the US in June of 2016. And now we have another FDA approved agent called copper-64 dotatate, or the trade name is Detetnec, and that was FDA approved in September of 2020. And both work almost the same. Moving on to prostate cancer, we have F18 fluciclovin, or oxamin. I'm happy to say that this agent was actually, Emory had a good hand, a significant hand in development of this agent. So this was FDA approved in May of 2016 for basically detecting suspected recurrence. So in the setting of biochemical relapse in prostate cancer patients, it's based on amino acid transport within the cells. Amino acid transport is upregulated in prostate cancer, but again, it is not that specific for prostate cancer itself. But here's an example of a tiny node, a 6 by 8 millimeter node just below the aortic bifurcation, and that was positive on oxamin PET, and directed biopsy of this confirmed that this was actually recurrent prostate cancer, and that kind of altered management, because lots of times if we don't find any disease, we empirically treat the prostate bed with radiation as treatment for these patients, unless we can find specific sites of disease. And for those who don't read much of these scans, this other hotspot here is actually the ureter, better seen on the sagittal and coronal projections and the MIP image. Here's another example of oxamin PET CT, just to show that it not only lights up in the nodes and visceral metastasis, but it also lights up on in bony lesions. Although the sensitivity is not as good, so people say don't use it as alternative to bone scans, but it can certainly be used as an adjunct, especially if the bone scan is negative and the pH is rising. You can certainly do oxamin PET CTs. The new kid on the block here is PSMA-based PET CT. Now, Europe and Asia has been doing PSMA imaging for much longer than us here in the US. We recently had approval of an agent called Pylarify, or F18P flufloblastat. It's a tongue twister. We just call it PYL, or Pylarify, and it was FDA approved in May 2021. It basically binds to PSMA, which stands for prostate-specific membrane antigen. PSMA is upregulated in prostate cancer, but unfortunately, again, it's not very specific for prostate cancer. And this agent is approved not just in the setting of recurrent disease, but also for detecting metastatic disease in initial treatment strategy, especially when you suspect that the patient is presenting with a advanced disease stage to begin with. And so here is an example of a patient with prostate cancer who underwent radiation therapy and is now suspected to have biochemical relapse based on creeping up of PSA levels in the blood, in the serum. And you can see that there is a focus in the left side of prostate that's concerning, and that was confirmed to be recurrent prostate cancer. Here's another example of a PSMA-based agent for prostate cancer. This patient had robotic assisted radical prostatectomy, and PSA levels were initially undetectable, but gradually have been rising for the past few years, and was 2.4 in G/ml at the time of this scan. And you can clearly see that there are multiple nodes scattered in the abdomen and pelvis, consistent with relatively extensive nodal metastatic recurrent disease in this patient. Another agent that has been recently FDA approved is FES, or F18 fluoroestradiol, for breast cancer ER status. The trade name for this agent is Cerianna. It was FDA approved in May 2020. And it was approved for detection of estrogen receptor status as an adjunct to biopsy in patients with recurrent or metastatic breast cancer. It is basically a synthetic estrogen analog that is tagged with F18 tag for PET imaging, and it binds to the estrogen receptors and allows us to visualize and quantitate the ER disease burden with PET or PET-CT imaging. The uptake of this agent in lesions depends on the ER density or on the cell surface, and it also is a function in tumors and physiologic tissues, including liver, ovary, and uterus. So basically, you can have some physiologic uptake in non-tumorous tissues as well. And it basically is found to have a direct proportion to tumor ER expression using in vitro assays. So the intensity of uptake corresponds to the ER density of the cells that is taking this agent out. We feel that the clinical utility of this may be to detect ER positive lesions in a breast cancer patient. So if we have multiple lesions, we know that not all patients respond well to hormonal treatment, and that may be because of known heterogeneity of receptors in patients with breast cancer. So if there are numerous lesions and only a few are ER positive, although the biopsy showed ER positivity based on one lesion that was sampled, then those patients may not respond that well. And so it could basically help in determining treatment with CDK4/6 inhibitors like palbociclib. Again, it can confirm ER status after biopsy, especially because not only is there known to be ER heterogeneity, but the ER status may change after time and especially after treatment. So sometimes patients who have become resistant to hormone treatment after some other treatments, they may have expression of ER receptors back, and they can potentially be rechallenged with hormonal treatment, and vice versa. Another avenue for use of this agent would be in invasive lobular carcinoma patients, where these patients are ER positive but are significantly understaged with FDG PET-CT because the lesions usually have a very low glycolytic index. And in this case, FDG scanning may show you the true or appropriate disease burden. And lastly, it can be used as a problem-solving tool when in patients with breast cancer, you have new lesions like a lung lesion or a brain lesion, difficult to biopsy. You don't know whether it's a MET or something else. In that case, again, if the lesions light up on FES scans are more likely related to breast cancer rather than something new in this patient. One caveat is if patients on selective estrogen receptor modulators or SERMs like tamoxifen or selective estrogen receptor downgraders, or we call them SERDs, like Faslodex, they need to be off of those for either 8 or 28 weeks. That's a long time, and so that may be difficult. However, patients who are on aromatase inhibitors like Femara or Arimidex or Aromacin, they don't have to be off that because they don't affect the uptake, and so maybe that can help as we wean patients off and try to do a scan in some of these patients. As I said, CMS recently removed, CMS in the US stands for Center for Medicaid Services, Medicare and Medicaid. They recently removed the non-coverage determination for FDG PET for infection or inflammation imaging. This happened in July of 2021. And so we can probably get reimbursed depending on local coverage for FDG PET in the setting of, say, chronic osteomyelitis, or infection of the hip, or fever of unknown origin. A lot of hospitals had already shifted the fever of unknown origin work up to PET, but since reimbursement was an issue, it was not very commonly practiced all across the US, so there was a lot of heterogeneity. Here's an example of a patient with aortic valve replacement 4 years back who recently presented with bacteremia, and blood cultures were positive. TE was abnormal. There was concern for perivalvular abscess, and you can clearly see that FDG PET is showing uptake in that area, confirming that there is active infection going in that area. So future uses in this bucket might be for sarcoidosis, for follow-up of sarcoidosis, fibrosing mediastinitis, TB, diabetic foot, and so on and so forth. Moving on to future applications of PET, FAPI is an agent that we think can be very important. Could cause basically there was this big hit article in JNM in 2019 that shows that this gallium-68 labeled FAPI agent showed uptake in multiple different cancers. I think it was like 28 different types of cancers. So FAPI stands for fibroblast activation protein inhibitor, and a lot of work is focusing on that. With the zirconium based agents for immunopet may also be very important. PET for amyloidosis may become important. FDOPA scans for neuromuscular disorders, for congenital hyperinsulinism, FLT to assess treatment response, hypoxia imaging agents, and a few other agents we can foresee as future applications. Moving briefly to cardiac and neuro applications, and then I'll wind up with Theranostics. So we have FDG for dementia, epilepsy, recurrent tumor, and differentiating CNS toxoplasmosis versus lymphoma. We have 3 amyloid imaging agents, Amyvid or fluorobeta pair, Visamil or flutamidamol, and Neurasic or fluorobetaben. All these are FDA approved. We have a fluorotaucipir or Tauvid that is FDA approved as a tau protein agent. And then we have institutional approval of FDOPA that happened in October 2019, but it's not easily available commercially. So this is basically FDG PET with normal aging. In Alzheimer's disease, we have the posterior pattern of deficits, and in frontotemporal we have the anterior pattern of deficits, and this is Pick's disease of frontotemporal dementia. A lot of work has been done on basically objective evaluation of these scans. We had our own SPM analysis with our own normal database showing that it works beautifully. This is a patient with pretty early disease MCI that to the naked eye is normal, but there are deficits that are very hard to pick up, and objective evaluation picks up. But when the disease is pretty obvious, then the software is not that impactful. But in early cases, certainly it is very impactful. And so we have published a lot on this. And then we have the specific amyloid agents where it basically a negative scan has a very high predictive value. So this is a negative amyloid brain PET scan where you have predominantly white matter uptake and preservation of the gray-white interface. And when you have this scan pattern, this is not consistent with the neuropathological diagnosis of Alzheimer's disease. It has got a very high negative predictive value and very high specificity. On the other hand, when you have diffusely increased cortical uptake, loss of gray-white cortical differentiation, or if you have one area of intense gray matter uptake that is more intense than the adjacent white matter uptake, that's a positive and an abnormal scan. In the appropriate clinical setting, this is consistent with Alzheimer's disease. Although this, as I said, the specificity or a negative predictive value for a negative scan is very high, almost 100%. The sensitivity or a positive predictive value for a positive scan is not 100%, but still isn't. It's in the 90s, so it's pretty high as well. So here is a negative amyloid scan, but this agent is Neurology, so it's kind of similar. And this is a tau scan after a patient who had a positive amyloid PET scan. You can see that there are deposits of tau in the temporal areas, kind of FDG pattern, but a positive scan. And then a year later, this was in a research study, and you can see that the patient has progressed. So the intervention did not work. So we can actually pick up whether a patient is going to have Alzheimer's disease sometimes a decade or so earlier before the patient becomes symptomatic. And so that's very scary because that's the marker that becomes elevated very first, and the patient develops symptoms pretty late in the course of the disease. So we have a lot of leeway if we diagnose these patients earlier, and we can come up with something that can stop or even reverse the disease process. That would be extremely beneficial to this patient. So a lot of research going on in this. And in October 2019, FDA announced the approval of this agent, aducanumab, for treating Alzheimer's disease. So we believe that Amyvid and tau agents may play a big role in assessing these patients. Here is an AB133 research scan for Parkinson's disease, beautiful images in normal patient and significantly decreased uptake, and you can quantify this. This is F-DOPA in a pediatric patient for congenital hyperinsulinism that comes in two flavors, focal and diffuse disease, and this scan can help differentiate between the two. And management options are different for the two forms of disease. This is the focal form of disease here. Moving on to some technological advances, here is an example of a PEM machine, or positron emission mammography, for breast PET imaging dedicated. The beauty of this machine is you could actually have a built-in biopsy module that can actually look at the hotspot, localize it, and then get the biopsy at the same time in the same setting, revolutionizing care again. And so that's something that has been implemented in the past, but still we have to work it out how it will fit in the grand scheme of things, whether the patient will still need an FDG PET scan and those kind of things. However, the exciting development is the implementation of PET MR. The first PET MR was established at least in the US in 2008. At Emory, we recently started operations of our own PET MR, which is awesome. And so we have some examples here. Potential applications for PET MR would be obviously brain tumors, head and neck cancer, liver and pelvic lesions, prostate cancer, MSK lesions, breast, spinal cord, in pediatric patients because the radiation exposure is less. For functional brain studies with stimuli to look at different kinds of areas that get stimulated or not, with different incentives to the brain, like the reward center and those kinds of things. So this is a whole body FDG PET, a whole body MRI, and a whole body fused PET MR. We have worked out the algorithms to get SUV and attenuation corrected images that kind of match with the CT. This is high resolution MR with FDG PET showing functional imaging power of MRI. And in contrast to CT or PET CT, where the images are obtained sequentially, you get a rapid CT scan and then a whole body PET scan. MRI can be obtained simultaneously with PET. And so some of the PET MR images, if the PET is obtained for as long as the MR, are beautiful. We call them the super PET images because the resolution is just awesome. So here is a video of a net spot or gallium-68 donated PET MR, beautiful lesions, and this is courtesy of PET MR at UPMC. And on the next slide is another PET MR. This is from us at Emory, showing our first Pilarify PET MR, beautifully showing local recurrence in the left seminal vesicle, some nodes that would have been missed on the MR as normal appearing or even completely missed, and then a subtle osseous lesion that was intense. So certainly these are great images, and PET MR is expected to take things even further. Cardiac PET has been around for a long time. We can have perfusion imaging or metabolism imaging for different kinds of things. The flow metabolism mismatch, where there is a perfusion defect, but preserved metabolism is the hallmark of myocardial viability. You can evaluate these scans just as a rest stress SPECT or perfusion PET study, where you can quantitate how much percent of myocardium and how much grams of tissue is actually viable or not viable. And these can be done with SPECT rest images as well. And then you can actually use this for scar evaluation, where you can look in patients with arrhythmias, where you want to ablate the culprit area that is usually within an area of scar. So here, instead of looking at viability, we are looking at scar, and you found there's a big scar in the proximal lateral or posterolateral wall, suggesting that this is where the culprit area for the rhythm abnormality may be. And then our EP colleagues go in and make electroanatomical maps that correlated pretty well with the scar area, and within the scar area there they found the culprit lesion that was successfully ablated. So in the future, if they know where the scar is, it can save them some time and look at that area first to try the culprit area first. And then moving on, I had a video, but I don't think that's playing. I think. The video is playing now. It's just another example to show the electroanatomic mapping of the scar. Let's move on in a sense of time to next topic, which is basically sarcoidosis imaging. And so we do a rest perfusion and metabolism scan. And I like this schema of interpretation where if it's normal, there are no perfusion defects and just suppressed uptake. In early stage, there are no perfusion defects, but increased FDG uptake in the abnormal area, whereas the rest of the myocardium is suppressed. And as the disease progresses, you start getting perfusion defects of more and more severity, and then finally it becomes severe with focal uptake as well. Moving on to the theranostic approaches, we've been doing I-131 therapies for thyroid cancer, which is kind of a theranostics. We've been doing it with I-131 MIBG for neuroblastoma as well. So this is an example of that. This is a pheochromocytoma with I-131 treatments several times, stable disease. This is a pancreatic neuroendocrine tumor, widespread disease that was treated with Y90 DORA-TOC and good response subsequently. So lutetium 177 is the other new kid on the block, where we give a PRRT based on DORA-TET PET, and you get disease stabilization to sometimes partial to good response, which is kind of durable. And actually a lot more work is being done in Europe and even in Asia. So Back in 2018 or 2019, we gave this IASNM Shock and Nerve Award for patient care to Dr. Sanjana Balal, who was looking at results of actinium-225 dotatate for patients who were basically resistant to lutetium-177 treatment. So post-lutetium, actually, they were doing this treatment. So again, Europe and Asia are kind of ahead of US in this game. This SNMI 2015 image of the year harped on Theranostics, and we still getting there. PSA-based Theranostics is still not FDA approved in the US, and we are hoping that we will get approval this year and start these therapies pretty soon. A lot of people know this fantastic image where there was extensive PSMA-based disease in this patient with PSF almost 3,000, with actinium-225 PSMA therapy times 3, significant reduction, almost normal PSA, and then after one more cycle it became undetectable. So after lutetium, we believe that actinium-225 would be the game changer. We still have to do radium-223 based therapies. This is our paper of its application in breast cancer, where the patient did very well and the markers went down very well. So people are looking at it as well. So in summary, FDG-PET is now routine for oncology in cancer, and cardiology and neurological applications have picked up as well. Hybrid imaging is expected to be the new norm and is going to drive the era of molecular imaging into P4 medicine. And we basically can take advantage of it to assess response more accurately and make changes to treatment in a timely manner. Newer advances, I believe, will be driven by newer radiopharmaceuticals or molecular imaging probes like PSMA, FES, Tau, Immunopet, and others. Technological advances will drive the field as well: PET MRI, PET mammo, maybe PET CT guided biopsies. And then Theranostics is supposed to play an important role in the future of nuclear medicine. So gone are the days where the nuclear medicine physician just sits in the reading room and reads at a few scans that are kind of like dots. Now he or she has to interact with an array of things, not just the patients with treatments, patients' family members, nursing, CNMTs, physicists and RSOs, clinical coordinators, radiopharmacists, radiochemists, the industry, regulatory entities, insurance companies, administrative people, billing and coding people, other radiology colleagues, other clinical colleagues. So it's basically becoming a very different field than what it was even a few decades ago. And with that, I will stop and take any questions. Thank you.